Yeah.
Oh, fine, fine. So, good evening, everyone. I'm Dr. Soumya. I'm the newly elected president for AFPI Karnataka chapter. And here we have our first webinar series coming up from AFPI Karnataka chapter. And the topic for today is approach to hypothyroidism in family practice. Hypothyroidism is a very challenging topic because especially the subclinical variety is something which becomes even more challenging. And it's a very common topic which we encounter in day-to-day practice. Maybe uh, a young lady coming with constipation with features of hypothyroidism, or maybe a pregnant lady coming with varied symptoms, including excessive vomiting. And so we thought that because we as practitioners deal with this particular problem day in and day out, it is wiser for us to discuss more. And we have a team of doctors here, experts from our own family medicine and also from endocrinologist. And we have Dr. Madhumita here, who is our scientific chair for all the upcoming sessions. She's the newly elected, very energetic, diligently working scientific chair, and we are very fortunate to have Dr. Madhumita with us, along with some senior mentors like Dr. B.C. Rao and others. So, over to Dr. Madhumita without wasting much time to know more about this particular and also to know about speakers and what they can add on to our existing discussions.
Thank you, Soumya ma'am. I would like to welcome all of you for this webinar. Without wasting much time, I would like to introduce our moderator and chairperson, Dr. Aditya. He is practicing as a consultant endocrinologist at Manipal Hospitals with more than a decade of expertise in this field. He has received award of President in NDE Gold Medal in endocrinology. He has many international publications. He is a member of Karnataka Endocrine Society and ISBMR. Our speaker for today is Dr. Bhuvneshwari. He is a consultant family medicine and diabetologist practicing at PD Induja Hospitals and with more than 30 years of experience. She is also a visiting faculty at Satyasai Hospital. He is academically oriented and has participated in academic events and is also conducting regular online classes for students at St. John's Hospital. He got distinction and overall academic excellence in DIFP. I welcome you both. I would request Dr. Bhuvneshwari to start the talk.
Good evening, all. Thank you for the kind introduction. The learning objectives for today will be quickly I'll go through the definition, causes, clinical manifestations, laboratory testing, subclinical, as Dr. Soumya had mentioned, treatment with levothyroxine, special situations, how we tackle, and euthyroid 6 syndrome, and common questions as family physicians, what we encounter in our day-to-day practice. Okay, so we as family physicians, we have a big challenge to mitigate because we will be the first point of contact when we come across patients, and we will make the diagnosis first. And they will be on follow-up with us regularly. Can somebody take over this one, because the admit is coming here?
Yes, ma'am, that's being done from our end.
Okay, thank you. So, as we all know, 42 million people in India suffer from thyroid disorders. Hypothyroidism, both overt and subclinical, is the commonest thyroid disease, affecting approximately out of 10 persons. We all know primary is primary thyroid gland failure, and secondary is due to failure of pituitary. So basically there is reduced production of thyroid hormone, which is called as hypothyroidism. So the common causes in primary, the most common cause is Hashimoto's thyroiditis, atrophic thyroiditis, and iodine deficiency, which is very rare nowadays after the iodized salt. And uncommon causes like subtotal, total thyroidectomy, radiation post 131 iodine therapy for thyrotoxicosis, external radiotherapy to head and neck, infiltrative diseases, thyroid dysgenesis, and few drugs like amiodarone, interferon alpha, lithium, iodine, congenital hypothyroidism, where there is an absent or ectopic thyroid gland, which is like 1 in 4,000. Okay, and the coming to secondary hypothyroidism, the pituitary is the main cause. The most common causes being tumors, trauma, surgery, infiltrative disorders, and also idiopathic. Same with the hypothalamic disease. There is an entity called a transient hypothyroidism, which is called as a painless or a silent thyroiditis, postpartum thyroiditis, subacute thyroiditis, after withdrawal of thyroid hormone therapy in a euthyroid patient. So all of you know this will be like a spotter when a severe hypothyroidism patient walks into your clinic. So I will not go much into detail, but so the common presentations, patients themselves, they come with typical symptoms like I feel so cold and I have a very dry skin, severe body pain, constipation, weight gain, puffiness of the face, hair loss, and menstrual irregularities, right from amenorrhea to menorrhagia and oligomenorrhea, and people newly married coming with infertility symptoms. Less common will be carpal tunnel syndrome, sleep apnea, hyperprolactinemia, which in turn can cause decreased libido, and hyponatremia. These are all very less common complications, but we come across these patients in a regular OPD and casualty settings. Atypical presentations, sometimes the patients are brought with short stature, their parents are anxious, they come with hearing loss, they can have conductive deafness due to fluid collection in the serous cavities in the middle ear, low academic performance, pericardial effusion, unconsciousness mainly due to hyponatremia and mixed edema. The most common symptoms are slow movements. As I told you, this will be like the patient as he walks in, you can make out they'll have coarse faces and the lateral eyebrow thinning, macroglossia, cognitive impairment. They will have a really husky, hoarse voice. They'll have goiter, bradycardia, mainly due to decreased heart rate, dry core skin, cool peripheral extremities because the blood flow is diverted from the skin, hypothermia, pleural and pericardial effusion. They will have non-pitting pedal edema, non-pitting edema because of the fluid accumulation, hyporeflexia, delayed relaxation of the reflexes. They can have diastolic hypertension and low voltage ECG. So just for completion's sake, I'm just adding these two, which is called as Wolff-Chaikoff and Jod-Bezdorf defect. When we have a higher dose of iodine, it will cause cessation of the hormone. This is by the leakage of iodine from the thyroid tissues. Patients with autoimmune, they fail to adopt and they become hypothyroid. The opposite of this is the Jod-Bezdorf effect, where what happens is excess of iodine, it will cause hyperthyroidism due to a loss of autoregulation. We can typically see this in Graves' disease, toxic multinodular goiter, and toxic adenoma. So what are the common lab values, lab testing we do in hypothyroidism? Only one test is enough, okay? That is TSH. This is the most sensitive test in detecting hypothyroidism. Combination of T4 and TSH will help us to distinguish between primary and secondary hypothyroidism. Free T3, T4, expensive, it is used only in some settings, and anti-TPO antibodies, if needed, it can be used in specific circumstances only to diagnose autoimmune thyroid disease. So we'll come across all these in the later presentation. As you all know, in hyperthyroidism, the TSH is low, T4 is high. Hypothyroidism in primary, TSH is high and T4 is low. In secondary, the TSH can be low normal and the T4 will be low. Thyroid ultrasound, high resolution ultrasound is the most cost effective imaging, especially with nodular thyroid disease. It will help, it can define the thyroid structure and also detect the surrounding lymphadenopathy. It can differentiate between malignant and the benign patterns. In malignancy, you will have hypoechoic solid nodules with infiltrative borders and microcalcification, whereas in a benign, you will see like a spongiform nodules with multiple internal cystic areas. Okay. And it is also useful for aspiration of nodules and cystic lesions. Helpful in ultrasound guided FNA, it lower the rate of inadequate sampling and decreases the sample error, so thereby reducing the false negative rate of FNA cytology. How do we evaluate? So when you measure the TSH, And the T4, T3, TSH is more than 5.5, measure the T4. If the T4 is below normal, straightforward diagnosis, this is primary hypothyroidism. Whereas if T4 is within normal range, it's like TSH is slightly high, it's called as subclinical hypothyroidism. We can consider treatment only if it is more than 10, but certain situations need treatment even if it is less than 10. And if the T4 is above normal, TSH is more than 5.5, it's not primary hypothyroidism, so we may need to refer to an endocrinologist for further evaluation. So we have different clinical scenarios to make the presentation interesting. Please, this is an interactive session, so please come forward and share your answers also. So case 1, 25-year-old lady, married since 2 years, anxious to conceive, complaints of severe fatigue, dry skin, constipation since 1 month. Physical examination results were normal except for a diffuse firm goiter. So the lab values are like this, the TSH being slightly above the normal range. What's your diagnosis? How will you approach this case?
Participants can unmute and also talk.
Ma'am, this is subclinical hypothyroidism, but patient have symptoms. We should start with thyroid supplement.
Very good. Yeah, that's the right answer. So subclinical, that condition because the T4 and the T3 are within normal range and the TSH is slightly raised. Okay, and patient has symptoms and she is anxious to conceive. So this condition is called subclinical hypothyroidism. And if patient is asymptomatic, see this patient has typical symptoms, so you can straight away start on the medication. But patient is asymptomatic, you can do anti-TPO antibodies to consider whether to start on treatment or not. Okay. So basically subclinical is a clinical diagnosis. It's not a clinical diagnosis, but it is a biochemical diagnosis. Most of them will not have typical symptoms. Okay. So we can start with 25 to 75 micrograms per day to maintain the euthyroid levels, and we can repeat the test after 6 to 8 weeks. So there are certain...
Bhuvaneshwari.
Yes.
Can I come in?
Yes, sure.
How do you say it's subclinical hypothyroidism when the clinical features are present?
No, this patient, the lab values are like subclinical, but she has few symptoms.
Then you won't call it. Then you won't call it subclinical. It's obvious.
Yeah, this case, of course, this is because the TSH is slightly high. If it is more than 20, we definitely call it as primary hypothyroidism. The T4 and the TSH is normal. The T4 is not low.
Okay. You see, the values can be like this, but the point is, this kind of lab value, one can have very little or no features at all in clinical practice. Then you should consider to treat or not. In this patient is overt case wherein you can't call this. This is a mild case of hypothyroidism, and I would consider it as not subclinical.
Subclinical. Okay. So, Dr. Aditya, you would like to add?
Yeah, so I think why they made it subclinical because there are no hard signs to say that, yeah, as you said, someone walks in and you diagnose it as hypothyroidism with features and lab values, everything fits in, probably, yeah, clinically it is hypothyroidism. Probably there are no hard signs or symptoms, but the lab values or other things say that yeah, it is to be treated. That's why probably it's put in the subclinical category. Subclinical, probably that is the only meaning.
Maybe we have picked up early in her case. Yeah. Maybe, yeah. There are compelling indications in a patient with subclinical hypothyroidism. There are compelling indications for therapy. What are these conditions? Patient presenting with a goiter and who has dyslipidemia, depression, infertility, planning pregnancy, hyperlipidemia, patient with carpal tunnel syndrome, menstrual irregularities, positive anti-TPO antibodies, unexplained hyponatremia, typical symptoms of thyroid failure, and those with psychiatric disease. These patients, definitely we should start on treatment. We don't wait till it crosses 10. Okay. So this is a flow chart. How do we, start treating? How do we work up patient with subclinical hypothyroidism? In the presence of normal T4 and the TSH is higher than normal, if you are in doubt, like how sir told, if patient doesn't have symptoms, if you are in doubt whether it is subclinical or not, you can repeat again after 2 to 4 weeks and then see the values. You can even repeat after 6 weeks and see the values. If the TSH is more than 10, definitely you start on treatment. Treat with levothyroxine. And if you are in doubt, check the anti-thyroid antibodies. If they are positive, definitely start on treatment. If it is negative, but patient has symptoms, start on therapy. Between 5 and 10, that is the gray area. We don't know. We are still in doubt. Do the anti-TPO antibodies. If it is positive, start on treatment. If the anti-TPO antibodies are negative, you can wait and watch. You can again retest again after 6 months. So how do we treat? In overt, the starting dose is 1.6 microgram per kg per day. So ideally, we tell the patients to take it on an empty stomach because there are a lot of interaction with medication and food. So we tell them leave a gap of minimum 30 to 60 minutes before breakfast. Or if patients are on too many medications and some of the patients have other comorbidities, so they take some of the medications on an empty stomach, we also tell them they can also take it at bedtime if there is a gap of 2 to 3 hours after dinner. Older people, those with IHD and severe hypothyroidism, start with a low dose. And you can recheck the TSH levels after 6 to 8 weeks until the TSH target is achieved. So the dose adjustment we do either with 12.5 or 25 microgram per day at each visit. Coming to the second case, a 50-year-old lady weighing about 60 kilos. She was diagnosed to have hypothyroidism. She was started on LT4, 100 micrograms per day, as the TSH was 64. So the results are shown here. We started with 100. It was
can't see the chart.
We are able to see, sir.
You can just tell T3, T4, TSH value.
Yeah.
Before and after treatment.
Yeah. So the 8 weeks later, the T4 is 7.2 and the TSH is 10.2.
Yeah, I can see now.
How will we approach this patient? She has come to you after 8 weeks.
A kind request to all the participants to mute unless you have any queries or concerns.
Switch to 75 mics for the next 3 months and repeat.
No, the TSH is still 10.2. It is not normalized. She is already on 100.
Ma'am, we can continue 100 levothyroxine for 3 months and we can repeat after 8 weeks again.
Yeah,
if symptoms are there, like if patient has symptoms, then we have to increase the dose by 12.5.
Ideally, we have to first check the compliance, how patient is taking, okay, whether she is taking regularly, whether she is skipping the dose. Then also ask for detailed history, whether she is on any other medication, as I told you. Okay, then still all that is negative, then you can increase the dose, to another 25 or 12.5 micrograms, and then recheck again after 2 to 3 months. That is the right approach. Dr. Aditya, you want to add anything here?
Yeah, first thing, as you rightly said, compliance. So one thing is, moment our patients realize that this is for life. So compliance is always a challenge. So invariably, they do end up missing many of the doses. The second thing, as you told, we always have to ascertain whether they are giving at least 1 hour gap after the tablet. So that also is always a problem. Also, very commonly, they take antacids, many things they do take. So we know that there are drug interactions, there are interactions with coffee, tea, all those. So these two things, as you rightly said, is the first what we have to
Sir, I
see.
beg your pardon, sir, but
Bhubaneswar,
your
one,
voice is very feeble, sir. And
Yeah,
second thing, this patient has responded within 8 weeks from 64 to 10.2. Isn't that a good thing? Should I
agree.
wait for another month with the same dose and then recheck? When do I expect it to normalize? Within
Perfect,
eight
ma'am. So,
weeks?
yeah, usually within the first 4 weeks, we do expect excellent response. And usually, what we say is a target TSH level should be at least around 2.5 to 3. So at that level, we have seen that the symptoms or otherwise, the treatment is optimal when TSH level is around 2.5. So in case she has taken regularly, she has given sufficient gap, even then symptoms are there. And I think this is quite a good enough dose. That's what Madam told. 1.6 microgram per kg, a 60 kg lady, it is quite a good dose. So in spite of all this, we even after 8 weeks, we haven't achieved target TSH levels. I think compliance is definitely
Family
what we
decision
will.
போ பிரபாகர் கர்நாடகால தான்
Yeah. So yeah, it's worthwhile looking at those two, and then
ரெண்டு பேரும்
we
நாங்க
have
ரெண்டு
to.
பேரும் ஏய் என்னடா ஏய் ஆமா பின்ன இது என்னது
Shall I go to
Non-participants, can you please mute?
Yeah, ma'am. Next slide.
Shall I go forward?
Yeah, ma'am. Please.
So coming to the next case, 48-year-old gentleman came with facial puffiness, constipation, cold intolerance 2 years ago, and the thyroid function test was done. He had typical features of a hypothyroid. So his TSH was 148 and he has been taking 150. Patient couldn't visit the hospital due to COVID situation, and LFT was done, TFT was done. So when he came, the T4 is 8.2, the TSH is 49. So he has come with a lab report to ask you whether should I continue the same dose or what should I do. He has come back to us after 2 years. In between, he has not come to us at all. So what do we do with this case? Anybody?
Yeah. So again, ma'am, so this I think was a very common case scenario. COVID, no follow-up, nothing. So invariably, I think compliance is an issue. So patient is happy, he has not seen the doctor, medicines have stopped. So I think compliance again we'll have to check.
Yeah.
So that
I
would be
think
my first thing.
he has just taken the tablet just 2 to 3 days before visiting the doctor. That's why I think T4 is normal. TSH is yet to normalize. I think that is the situation in this case. Again, compliance. Case 4, 54-year-old lady, presented with complaints of on levothyroxine for the past 100, for
one
the past
second,
5 years.
Bhubaneswari,
Yes, sir.
that previous case needs to be handled well, in the sense you have to get that man to come back again after 2 months, check again and to see that there is a drug complaint or otherwise, if the same thing persists, and that would be a different scenario altogether.
Yes, sir.
Yeah, okay.
I think COVID time we have seen many, and usual normal time also we see like this. When they suddenly they remember, they start taking the tablet, they come to us, they will look at our face and ask.
No, that's not what I am talking about. I'm talking about a compliant patient.
Yes.
Coming with this picture would be a different, ball game altogether.
Yes.
So you will have to counsel that guy to come back again with the reports after 2 months,
Yes.
and see how things are.
Yes, sir.
Huh?
Yes.
All
Sir.
right.
Yes.
Okay.
54-year-old lady presented with complaints of hypothyroidism. She was on levothyroxine 100 per day for the past 5 years. She is also on iron pills because she was anemic, and also she has been taking calcium supplements. Okay. Her TFT reports are as follows. As you can see, the T4 is okay, T4 T3. TSH is slightly high, 15.5. So how will you approach this case? Anybody?
Yeah, so I'll be into it again. I think it is there in the question itself. She is probably combining it with iron pills and calcium
Yeah, I
supplements.
know.
And this is a very common scenario. So many of the patients, they just take everything together, all whatever antacids, whatever given, take everything together in the morning first thing. And then, so they tell us that either your medicines didn't work, I don't have any relief from symptoms, so something must be wrong. So, it's very evident from the question. I think that is what she has been doing.
So why then the previous scenario, we are trying to reason out for the normal T3, T4 and the high TSH, despite patient telling that I am taking the medicine. First thing is, as I told you, it is non-compliance. We should always check with the patient whether they are taking it regularly every day without missing the dose. Loss of potency of the drug. Sometimes they open, keep it outside, they don't close it. So many things happen. And they keep on changing the brand names, okay? They keep on changing. One time the Euthyrox, one time Thyronorm, like that, Eltroxin, like that, they keep on changing. All that also matters. Like the previous clinical scenario, drug interaction with Eltroxin, especially when they are taking antacids and iron and calcium tablets. Ideally, they should leave a gap of minimum 4 hours. So supposing if they are taking levothyroxine in the morning, they can take the iron tablet in the afternoon, and so that there is a gap. So we should advise the patient, and also sometimes they don't leave a gap, they take with food immediately. So patient on OC pills and on other antidepressants like TCAs, sertraline, SSRI, patient on carbamazepine and phenytoin. So all these drug history we have to take in detail to know how they are compliant, and to interpret the reports. So as I told you, if they are on multiple medications, they can take it at bedtime, ideally with 3 hours after the meals. Okay. Coming to the next.
Just to add, as sir rightly said, so everything is fine, compliance is good, and still thyroid levels, TSH levels don't come down. Probably we have to strongly suspect malabsorption or other disorders as well. We do 84 absorption tests and all those, as sir rightly said. So in some patients, definitely a simple disease like hypothyroid can be a bit challenging. So we rule out all this, still we don't achieve targets, then probably malabsorption and other things do play a role.
Next clinical scenario, 60-year-old lady, she was brought to the casualty with altered sensorium. Her sodium levels are 110 milliequivalents. Rest of the lab reports are normal except for the TFT, which is like T3, T4 is very low. TSH is 72. So how will you interpret this?
Hyponatremia caused by hypothyroidism.
Yes, yes. It's very common in the elderly, so we should keep this in mind. So,
and the elderly also, these guys drink a lot of water. Somebody tells them, you drink a lot of water, it's good for your health. These guys drink so much of water, even otherwise they're going to hyponatremia. Adding insult to injury, he is also doing this. So that could be that could be the reason.
And many elderly want to control salt because they are hypertensive, and at home they hardly have any salt intake. That is also one. And many of them are on diuretics and other side effects. So we need to also correct sodium here, possibly, and recheck FT4 TSH.
I think it's after ruling out cortisol insufficiency.
yeah.
So that thyroid.
Yes, definitely agree.
Correct, yeah. So, shall we go on to the next one?
Yes.
70-year-old gentleman, he was brought to the hospital with complaints of memory loss Detailed evaluation was done by a neurologist. All the routine labs were normal except for a deranged thyroid function test. So in an elderly, like the T3, T4 is it's normal, but the TSH is slightly elevated, 6.7. How will you approach this case?
I don't know. I would have given him a very, very small dose of eltroxin and watch him.
Yeah, we first have to rule out any cardiac issues in elderly. In the absence of any arrhythmias, we can slowly add a small dose of eltroxin. It does help in memory improvement.
Ma'am, is there any thing that the cutoff should be, or rather the cutoff is higher for elderly before we intervene, say 12 or something?
Yes, I'm coming to that actually.
Okay, ma'am.
Yeah. So in this case, because he's an elderly with memory loss, we should also look into other B12 deficiency, all that. Okay, before we conclude he has hypothyroidism. In elderly, that's what I'm going to tell you. As people age, there is an age-related elevation in the TSH. That is a protective phenomenon. So slight increase in TSH when patient is asymptomatic, it can be ignored. But if they have coexisting cardiac disease, it's better to start with a low dose like 12.5 to 25, increase it very gradually over 3 to 4 weeks. Okay. As Dr. Soumya had told, maybe we can start on a small dose. Dr. Aditya, what is your take on this?
Perfect, ma'am. So we can start with 12.5 and then slowly up titrate.
Yeah, yeah.
4 to 6 weeks.
Yeah. 52-year-old gentleman comes for with complaints of severe fatigue and muscle aches. He's not a known diabetic or hypertensive. On routine investigation, he had dyslipidemia. I think we will have such cases in our OPD. The total cholesterol, triglyceride, LDL, everything is high, and he had come with deranged TFT also. So as you see, T3, T4 is very low, TSH is high. So how will you approach this case?
Of course, dyslipidemia has to be treated because it is known that people with hypothyroidism have high triglycerides and high cholesterol levels. Simultaneous treatment is required for both.
Yeah, should we start on thyroxine first or statins first?
Yeah. One catch here is his LDL is quite high. We usually expect mixed dyslipidemia, both LDL and triglycerides, but his LDL is probably slightly higher than what we expect even in overt hypothyroid. And if there is a strong family history of CAD, especially premature CAD, then yes. If the LDL levels were slightly lower, then probably I would have treated thyroid first and then probably started. But in this case, no.
So as you all know, hypothyroidism increases the cholesterol protection slightly, and it reduces the cholesterol clearance, leading to dyslipidemia. So dyslipidemia in a patient with overt should not be treated unless the TSH levels are stabilized. You can wait, as Sir has told, we can wait. But in his case, LDL is also very high, so we may need to treat. Probably, Sir, I think we can start on the eltroxin, give a gap of 2 weeks, and then start on the statin also. What do you say?
I would give both together.
Because we may start on a big dose also, the statin, because it's very high. So
not necessarily. Start with a small dose and build it up.
Okay, sir, Dr. Aditya, what is your take in this?
Yeah, ma'am. So I think we can start with the lowest dose and then up titrate. But in this particular scenario, probably both.
More, yeah. Okay. So treat with levothyroxine itself will correct the dyslipidemia if it is marginal increase. Okay, in his case, this is slightly more, so we may need to treat simultaneously. Okay, coming to the next interesting scenarios. 26-year-old lady, pregnant lady, she comes with an abnormal thyroid function test. She is in her first trimester of pregnancy. So as you can see, the T4 is slightly on the upper limit of normal and the TSH is 5, slightly above normal. will you start treatment? If so, what
Yeah.
dose?
So pregnancy again is particularly challenging. So one thing is we know because of the hormonal changes in pregnancy, beta HCG increasing in the first trimester and then TSH stabilizing there afterwards. So no question in pregnancy the target TSH levels are also slightly different, and the threshold for treatment in pregnancy is much lower. So we usually say any TSH more than three, more than four, so definitely yes. More than three also we do treat. That is for pregnancy or someone with irrespective of the TPO usually. And the target levels of TSH are usually between zero point 0.3 to 3 in first trimester, then 0.2 to 2.5 and 0.1 to 2.5 in the second and third trimesters. So pregnancy is a different, and that is because of the hormonal changes. The second scenario is when one who is already taking thyroid supplementation becomes pregnant. Many of the time we see that also. Invariably, the doses only increase in pregnancy because that is important for both the maternal health as well as the health of the fetus. So pregnancy we cannot wait and take chances. And as the pregnancy or the duration of pregnancy increases, the dose gradually increases. And again, post pregnancy, we usually reduce the dose probably to the pre-pregnancy levels. So pregnancy, I think, is one thing where there should not be any doubt in treatment.
Better to start.
Yeah, no question.
No question.
What is the dose?
Yeah, so again, yeah, I think partly it's here. So someone who is a known hypothyroid already on a medication, as a rule, so the moment the patient comes to us saying that she is pregnant, we increase by 25 to 30%, as madam has rightly said. Or in a simpler way, you just increase the same doses on weekends. Suppose she was taking 50 every day, weekends you can make it, you can double, make it 100. That is as a rule of thumb usually. And then as per the results, keep TSH anywhere between 2.5 to 3, adjust your dosages accordingly.
Yeah, that is a summary. Sir has already told about that. So why it's important to treat hypothyroidism pregnancy? As Sir told, there is a firm association between hypothyroidism and adverse risks to the mother and the fetus. Why? Because there is increased rate of overall pregnancy complications, impaired fetal neurocognitive development, premature birth, low birth weight, miscarriage, gestational hypertension. So we have to treat, even if it is 5, we have to definitely treat. So these are the cutoff values in pregnancy, as Sir told, 2.5 to 4. I think ATA 2017 recommends the cutoff is slightly higher. They have kept it as 4 in India. And second and third trimester is 3. Okay. Why it happens? The low TSH in the first half of pregnancy, it is normal because the HCG takes over the work of TSH. Both the structures of HCG and the TSH are similar, and there is increase TBG because estrogen induced increase of TBG, so the total T4 will be more. So that is why. Okay. So coming to the next scenario, 60-year-old, 25-year-old lady, 60 days postpartum, she was brought to the hospital with extreme tiredness, constipation, sleepiness, not interested in breastfeeding her baby. She's dull looking, she's not making any eye contact. Okay, her routine labs were sent and urine routine, everything was normal except for she was little anemic. TFT also was done as a routine. So this is the value. As you can see, T3, T4 is very low. TSH is slightly high. So what's your diagnosis? Anybody?
Sorry. Okay. I think this is also probably we see around 10 to 15% of cases postpartum thyroiditis. So sometimes there can be postpartum autoimmune thyrotoxic. then it can be silent, then destruction leading to hypothyroidism. So this is, we have seen at least probably 10 to 50% of patients this can happen.
Postpartum thyroiditis.
Yeah. So initially, the hyperthyroidism is missed. Thyrotoxicosis is often missed, but the patient will
Silent.
present with hypothyroidism only. So we need to treat this, and she will need regular monitoring of the TSH. So for completion sake, I thought we'll also touch upon the myxedema crisis.
Bhuvaneshwari,
Yes, sir.
that previous slide needs a little more of a detailed explanation because very important.
Which one, sir?
Not this
No,
one.
no. Yeah, what happens? Thyrotoxic phase, normal
Yeah,
phase, then the
this
destruction
one.
leading to hypothyroidism.
Yeah.
You want me to go through this?
Yeah, same thing.
So
What's the same?
So this is not autoimmune thyroiditis. This is different, isn't it?
Partly autoimmune also, sir.
I see.
There will be some TPO positivity also.
I see.
Usually, otherwise it is like post-viral, all those can overlap, but autoimmune does have a role in this.
So when you see thyroiditis in clinical practice, not necessarily postpartum.
Yes.
That is also autoimmune, or is it due to some other viral illness? Or
Viral, yes, sir.
something?
Viral. Most commonly, if we take common case scenario, it is post-viral, sir, as you rightly said.
So postpartum thyroiditis presenting like this needs very urgent treatment.
Yes, sir. Yes, sir.
And kind of a crisis situation this is.
Yeah, yes, she needs treatment.
Okay, thank you.
We can miss it because we may think like depression because her features are like depression.
Yeah,
so we have done the thyroid, so we will pick it up. Otherwise,
so routinely you must do thyroid function in these people. Yes. I think it's a very good, very important take-home message.
Yes.
Thank you.
Yeah, because the symptoms are more like depression. Postpartum depression also will be a DD in this, so we can miss it. So postpartum thyroiditis need to be treated. So I think this is a very rare, but maybe sir must have seen Dr. Aditya. So yeah, it's a myxedema crisis. I think coma, they have changed to crisis now, the latest. So it's an uncommon life-threatening form of severe hypothyroidism with systemic decompensation, more commonly in elderly. It occurs in hypothyroid patients suddenly stopping the levothyroxine on their own. If they are on a big dose, they have stopped it. All the patients, they may not present with coma, but they can present with stupor, altered sensorium. So what are the precipitating factors? They can be CVA, hypothermia, infection, CCF, any drugs, GI bleeding. So they can, again, the hyponatremia, where we had a similar case in the past, in the previous presentation, hypoglycemia, hypoxemia. So typical clinical picture will be like, they'll come with severe bradycardia, hypotension, hypothermia, hypoventilation, hypoglycemia, they'll be in coma, hyponatremia. So how do we, this is a emergency case, so how do we treat this patient? ABCD. So we start on IV hydrocortisone 5 to 10 milligram per hour or 50 milligram 8th hourly, and cover them with blankets to prevent the heat loss. Treat the coexisting infection. So mortality is very high, 80% if treatment is not started within 24 hours. So we should make the diagnosis. Intravenous thyroxine 300 mics is the choice of therapy, but it can be given through an NG tube also. Then make it 200 micrograms per day. Intravenous preparation we don't have in India. So monitor the electrolyte, metabolic abnormalities. Okay, keep monitoring the patient. This is an emergency.
No, this is to Dr. Aditya.
Yes, sir.
Now, I haven't seen one in my 50 years of practice. I've seen severe patients with myxedema, but not this kind of a scenario. Have you had such
Yes,
cases?
sir. In fact, unfortunately, the patient also died in spite of he came quite late. By the time we diagnosed and we started treatment, he had an arrest. So we
Okay.
have seen, sir.
Quite infrequent it must be, but
No, sir.
suspicion
That was
one should
probably
have. Yeah.
one of that's one. After that, such severe cases I have not seen.
Yeah. So the message is that patients who are on treatment who suddenly stop, who are these days it's pretty common that they get lay advice, they switch to homeopathy, they switch to
Correct.
this that, and so one should warn them not to stop treatment whatsoever, especially the elderly who are prone to these problems anyway. Okay, good, thank you.
So this is another topic like secondary hypothyroidism. So we suspect this when there is no appropriate, increase. If you have a low T4, there is no appropriate rise in TSH. These patients, how they present is they do not have much weight gain. The skin will be pale, cool, and there is no goiter also. So features of an underlying pituitary tumor or the other hormone, pituitary hormone deficiencies, they may be present. So common presentation will be hyponatremia, okay? And we should exclude ACTH deficiency or other pituitary disorders before we start on treatment. Why this is very important? Because we give steroid first prior to giving the LT4. So this is very important. So how do we follow up these patients? In a primary hypothyroidism, we do only TSH. In a secondary hypothyroidism, we do both T4 and the TSH. So this is important. So Dr. Aditya, you want to add anything?
Yeah, so I think this is where they commonly refer to us.
Yeah, we
Confusing
referred.
sort of picture, T3, T4 low, TSH low normal. So this is when actually the endocrine gets a referral. So secondary hypothyroidism, I think very clearly said, we have to rule out the cortisol insufficiency. That should be treated first, then thyroid. And one important caveat is T4 should be also looked at for titration. So not only TSH, because we know TSH will invariably not change unless it goes very low, less than 0.01 and all, we know the dose is really high. Otherwise, in these patients, T4 or PT4 is to be utilized to adjust the dose. That is one caveat, unlike others where we just see TSH and adjust the dose.
Thank you. So this is actually by on request of Dr. Madhumita, I thought we'll add this also because some of us are in critical care also. So this is another clinical scenario where, we have to keep this in mind. A 65-year-old male presents to the, casualty with decreased urine output, and his surgical history is significant for a splenectomy, which was performed 10 years ago after a motor vehicle collision. His BP, as you can see, he's severely hypotensive, and pulse rate is 110. Temperature is high, respiratory rate is 30, SpO2 is 98 with 2 liters of oxygen, blood cultures are obtained. So he's diagnosed with pneumococcal sepsis, he's transferred to the ICU. So the lab report shows a decreased T3. So the patient, what is it he can have? Like whether it is Graves or subacute thyroiditis, increased concentration of TBG.
What interests me here, why did they do only T3, nothing else? Why not T4? Why not TSH?
Next slide, Prof.
No, I focused only on that so that it focuses on that, sir. All the other tests were also done, but because all the others will confuse us, so I just mention only that. Because this is a special clinical scenario, so we wanted to highlight that. That's why we mentioned only that.
Okay, all right.
We got the answer. One of the participants already.
There's the answer.
Yeah. So the answer is low T3, low T4 syndrome, which is called as the euthyroid 6 syndrome. So this we see in acute illness, especially patient is in an ICU, very sick patient. So we should keep this in mind. What happens is, during an acute illness, there is increased production of IL-6, IL-1 and TNF-1 alpha. What happens is there is impaired peripheral conversion of T4 to T3, which is usually done by type 1 deiodinase. So this will lead to decrease T3 and FT3. This is basically an adaptive response to limit the catabolic state. And because T4 is not converted to T3, T4 and the TSH will remain normal. On the other hand, because T4 is not converted to T3, the reverse T3 will be high. Okay, this is usually done by the type 3 deiodinase. So all these abnormalities are collectively called as low T3 syndrome. This happens in an acute illness. And the other side is, the other explanation is, very sick and moribund patient in an ICU, there is an altered binding of T4 to the thyroxine binding globulin by an unknown inhibitor. What happens is, so there is a reduction in the T4 and the free T4. So because of this, the TSH will be high and T4 is low. So naturally T3 and the free T3 also is low. Okay, this is called as low T4 syndrome. And in patient with acute liver failure who comes with severe sepsis and shock because of hypoperfusion, there is increased release of thyroxine binding globulin, which leads to increased T4. And also certain medications like heparin, this will also displace the T4 from thyroxine binding globulin, which will lead to increased free T4. And some of the drugs which we use in ICU in critical setting, like amiodarone and iodinated contrast, will decrease the hepatic uptake of T4, which will lead to increased T4. So this is called as high T4 syndrome. Also in ICU, we give cortisol either endogenously or exogenously in the form of steroid, and also we give dopamine, which will suppress the TSH, leading to decreased TSH. All these happens in a euthyroid sick syndrome. Okay, and most commonly low T3, this is the most common in 70% of the hospitalized patients, usually resolves on its own, but during recovery the TSH can slightly go up for a transient period. Whether to treat or not depends on the critical care specialist. Some recommend starting on a small dose, but depends on the clinician because it will resolve on its own. What is your take on this, Dr. Aditya?
No, ma'am. Usually no.
You don't.
It resolves. We give it time.
It resolves, yeah.
Yeah. So one learning thing is, yeah, as you have already shown, low T4 syndrome has a poor prognosis.
Poor prognosis.
That indicates that it is quite critical. Second thing is the TSH level usually don't cross 10.
Okay.
It is somewhere in between 4 and 10 only. Whatever CQ thyroid is, usually doesn't cross 10. So that is one thing we always should remember. If it crosses 10, very, very unlikely that it is CQ thyroid.
Okay.
TSH levels crossing 10. And most of the guidelines or most of the people agree that we don't supplement with thyroxine in CQ thyroid.
Okay. Okay. As family physician, we come across these common questions in our busy OPD. So I thought we'll go through this quickly. Should we give the blood sample for TFT on a fasting or not?
TFT fasting, only TSH, probably any time, but preferably fasting.
Okay. My patient TSH is not coming down. What should be done?
I think you've extensively discussed compliance, all those, and then the last part.
Yeah, the anti-TPO antibody is not coming down. What to do? Patients still keep asking like this.
No point in chasing TPO antibodies. Once positive, it's positive for life. So just do it once for reducing your headache. Don't repeat TPO antibodies.
My patient TSH is just above normal. Should I treat or not? I think we have done this.
Extensively we have covered
this. Should I take the LT4 on the day of giving the blood sample?
If fasting, not to be taken. Patient is giving it on a fasting or the fasting sample, no need to take. If he takes the medicine, we have to interpret the T4 levels. TSH will be stable for 4 weeks, 3 to 4 weeks. So it doesn't matter.
My patient is having a low TSH. Should I start on carbimazole?
I think this also you have already.
No.
Yeah. Is it okay if I skip my tablets 2 to 3 days in a week? Many patients do this actually.
Doesn't work. I think in between that come with once a week thyroid. Yeah, it didn't work that effectively. It did work, but not that effectively. So it was taken out. No point. So it has to be taken daily, empty stomach, and give half an hour. Yeah.
So I tell them sometimes if they forget, keep it near their wash basin where they brush their teeth. So they will forget. They will not forget. They will take it.
They will wash the tablet all down there.
I usually tell them to keep next to their pillow so that as soon as they get up, they pop up the pill and then they go, they brush and they do all the routines so that they have adequate.
Yeah. I don't get the same brand. Does it matter?
Ideally, it should not matter if it is from a standard company. But the thing is, even recently I saw yesterday, someone is taking something Thyropace or something in place of your levothyroxine. So that and all is quite grave. So at least it tells L-thyroxine with the dosage. I think I'm okay with that.
Should I avoid eating cabbage, cauliflower, rather? What are the food restrictions if I have thyroid?
No, I think you've already told iodine supplementation is universal and goitrogenic doses, like how much you don't take goitrogenic doses of eating cabbage, cauliflower, and all those, and not daily. Definitely, no one eats it daily. So no.
So these are the common brands in the market. Of course, L-Troxin is very less priced. Okay. So some quiz, is it okay? We have time or should we?
We'll put it up in the this thing group.
Shall I quickly run through? Or?
Wiser quickly run through because it becomes very interesting.
Okay. I think okay. 24-year-old primary with 40 days amenorrhea with history of hypothyroidism, already on LT4. How much percentage increase in dose requirement will be needed before they report to the doctor? Anybody?
Somebody answered that, not 20% or 50% increase. 15 to 20%.
25 to 30%.
Newly diagnosed primary hypothyroidism started on LT4. When is the monitoring of T4 TSH advised for follow-up?
6 to 8 weeks.
Yes, yeah. What are the cutoff values of TSH in pregnancy, first, second, third trimester?
1.2, 1.5 to 2.2.
First, second, third trimester.
2.533.
Yeah, correct. Very nice.
Yeah. So I think you have to tell prices at the end of the quiz. That's when
2.5 to 3.33. Okay.
68-year-old.
So they will come to Manipal to connect prices.
68-year-old diabetic and CAD with overt hypothyroidism. What is the recommended starting dose to normalize the TSH?
25.
25. Yeah, very nice. Myxedema crisis, severe form of hypothyroidism, most commonly occurs in which of the following?
Fourth one.
Fourth. Very good. Yeah.
Last one.
Yeah. Which of the following generally accepted as the most sensitive screening tool for primary hypothyroidism?
Second one.
Yes.
You're right. Second. Yeah. Which of the following is not a common physical sign of hypothyroidism?
One.
Jaundice. Ascites.
Jaundice.
ascites.
Ascites.
Old man, right?
Which of the following is which is the active form of thyroid hormone?
T3.
Right. The last one. Hypothyroidism can affect pregnancy.
Who's already pregnant?
3.
Make
attempt to
miscarriage more likely.
3.
Reducing the chance
Reducing
of
the
it.
chance of it.
Yeah. Okay. Any more questions?
You've done a great job in finishing right on time.
Thank you. Thank you, sir. So to summarize, hypothyroidism can be primary or secondary. Primary hypothyroidism where we have high TSH, normal T4, subclinical, it will be, normal T4 and slightly high TSH. Treatment of subclinical should be individualized based on clinical condition. Treatment of overt hypothyroidism is always with levothyroxine. Special situations like how we discussed needs careful management. These are my references. Thank you. Any questions?
If there are no more questions, then I would request Dr. Hema to give vote of thanks.
Madhumita, just before we wind up, I have 2 questions. Are there any guidelines for lipids in hypothyroid patient when well controlled? Are there any specific guidelines? And what is Dr. Abhijit, what is your comment on FT4 being altered with a normal TSH in a patient who comes for surgery?
Yeah, I think as per ADA, there are no specific guidelines for those in hypothyroidism. But again, so with overt hypothyroidism, as Madam rightly said, first thing is to treat the thyroid, see that TSH levels are normal, still lipids are abnormal, then only treat. So that is what everyone, all the guidelines do agree. Second one, free T4, as Madam has rightly said. So sick thyroid, someone who needs a surgery, but his thyroid levels are or the free T4 levels are abnormal or low normal or something. If the surgery is an emergency, probably we have to start supplementation, take him at a higher risk. And now that free T3 is also the LT3 is also available, it becomes a bit more complicated, the situation. But if the surgery, if there is an emergency, supplement probably cover with steroids and you have to take for surgery. There is no other option.
So you would see people come for fitness, for cataract surgery, small surgeries, for hysterectomy, or some minor or major surgery, right? So we also have a practice of doing, particularly checking this FT4 and TSH, and suppose it is altered and we start them to stabilize, we start them on eltroxin. Should we say that we have to wait for 6 weeks? Of course, there are multiple parameters here, considering the comorbid, the age of the patient, the presence of IHD and things like that. But as a general rule, what is your recommendation? How many days is 2 weeks enough or 6 weeks enough
four
to
weeks,
stabilize
definitely
them?
4 weeks. 4 weeks.
Okay. Thank you so much.
One last question. Now, for calcium supplementation when thyroid hormone supplement is given, this is necessary? Because I at that point was missed in this presentation. Hello, did I?
Yes, sir.
Yeah. What I said was calcium supplementation when you are you're replacing thyroid hormone. So thyroid, when you give any of these preparations, there is a catabolic effect and osteoporosis. Long-term use could be a problem. So one would give calcium supplements with vitamin D.
Agree, sir. But I don't think we suppress it to. We don't give a suppressive dose of thyroxine probably. So TSH levels going low, that probably is at putting them at a higher risk for osteoporosis.
Okay.
So
now routinely when you give thyroxine, you need not have to give calcium.
Usually no, sir.
Okay.
And some drugs like patient would be on cardrone and also would be on thyroid supplements, or patient is on lithium as well as thyroid supplement. What is your recommendation? The same 4 to 6 weeks once careful monitoring is required, or are there any guidelines or recommendations from your side?
Yeah, same time. Amiodarone is a bit challenging because the half-life is too long. The half-life itself is around 49-50 days. And it can result in various types. It can result in thyrotoxicosis, it can result in thyroiditis, hypothyroidism. Amiodarone is a bit challenging. So it depends on what was the need for amiodarone and how long are they continuing amiodarone. I think in present day practice, the use is only coming down. Amiodarone is no longer used as frequently as it used to be. And lithium also, again, if the indication is to continue lithium, no other option, we have to treat both. And yeah, same thing holds good. Probably amiodarone, I'd like to do every 3 to 4 weeks, lithium 4 to 6 weeks.
Thank you so much.
I request Dr. Emma to give the vote of thanks.
Yeah, thank you, Madhumita. First of all, my sincere thanks to Dr. Bhuvaneshwari for such a fantastic presentation. And ma'am, you have covered all important clinical aspects of hypothyroidism and so beautifully with through case scenarios. And I felt hypothyroidism will be a boring topic, but you have made it very interesting through case scenarios. And thank you very much. And I thank Dr. Aditya for his time and expert opinion. You have brought in a lot of clarity to our understanding. Thank you very much, sir. Hope to have you in many more sessions of AFPI Karnataka. And special thanks to Dr. Rao for sharing your experience and making it more interesting. And thank you all for participating actively. And I request all of you to join regularly for our webinars. We have planned it every second week of the month. And not and I also thank Madhumita for organizing this webinar. And see you all for the next webinar series. Thank you. Thank you for joining in.
Thank you, Emma,
Thanks,
Soumya, Madhumita. Congratulations. Keep it up.
Thank you, sir.
Thank you, sir.
And Aditya, thank you very much. Bye-bye.
Thanks, ma'am.
And we need your continued support for critical audits. Thank you, which is welcome.
Thank you. Thank you. Thank you for the opportunity. Thank you. Thank you, Dr. Aditya.
Thanks, sir. Thank you. Good evening.
Thank you, Dr. Soumya.
Thank you so much, both of you.